We go on to our next speaker. Thank you, Shrish. Dr. Sayan Basu, who needs no introduction, and he is going to talk on keratoprosthesis, current indications and techniques and preferred practice guidelines.
So my
Thank you,
talk
Dr.
is,
Sayan, for having supported me
thank
for innumerable programs in my ARC. Thank you so much.
you. It was an absolute pleasure, ma'am, and thank you for making me a part of this session as well. So I have a very simple uh, topic to talk on preferred practice patterns. The original topic was preferred practice patterns for keratoprosthesis. That is a very short topic for me to speak on because the preferred practice for keratoprosthesis should be that unless you are in a very large institute where you have great retina and glaucoma backup, don't do a keratoprosthesis. If you have a patient who needs a keratoprosthesis, send that patient to an institute where they can do a keratoprosthesis. So I changed that a little bit so that we have a little bit to talk about, and made it about if you have an indication like bilateral limbal stem cell deficiency, then how do you decide between doing an alloslet and a keratoprosthesis, which is more relatable and clinically would be more useful to discuss, and we can then build the preferred practice pattern around it. So this is the general algorithm that I think most people follow. It's very intuitive and it helps you to understand where you do what. So if you have a case of unilateral limbal stem cell deficiency, it might be chemical burns, it might be any other cause, but mostly unilateral LSCD is chemical burns. And there is visual potential in that eye, and the eye has a wet surface, then this is where you would think about doing an autologous limbal stem cell transplantation, which is basically an autologous sled from the other eye, and you would wait for the corneal stroma to clear over time. If you have a dry surface, unilateral, we usually don't do anything for these patients. It's important to emphasize here that these are not cases where you would do a keratoprosthesis. So typically we discourage people from doing keratoprosthesis if it's only in one eye. In bilateral LSCD, you're more desperate, the patient needs vision, and therefore in these cases your options are more complicated. Either you can do an allogenic limbal stem cell transplant, which is where an alloslet comes in, along with a keratoplasty, along with systemic immunosuppression, or you can do a Boston type 1 Kpro if the eye is wet, or more complicated forms of Kpro like the MO KP, the type 2, the LVP Kpro like Shreya showed, or Lux keratoprosthesis, which is also available now, where the surface is dry. If there is no visual potential, again, in either case, you will not do any surgical intervention. So if you look at the causes of bilateral LSCD, chemical burns is number one cause, and then you have allergic eye disease in India, SJS and pemphigoid. Now, these are two very useful articles to understand what is the logic that you use. One is in the ocular surface, which is surgical management of bilateral limbal stem cell deficiency, which basically shows that the outcomes of keratoprosthesis are good in the short term, but not sustainable over a very long period of time unless you are able to change or exchange the keratoprosthesis. Whereas the visual outcomes in limbal stem cell transplant is more sustainable, but not as impressive initially as a keratoprosthesis. So the absolute benefit you get in terms of what the patient sees is much greater in keratoprosthesis, but the duration for which they have that benefit is shorter. And the other problem with keratoprosthesis is that the risk of complications, especially severe vision threatening complications, is very high. So, and this is basically why you have to be very choosy about doing keratoprosthesis, and as well you have to have the backup to manage these complications, which are mostly surface related, cornea related, infection related, but also could be glaucoma, which almost happens in 40 to 50% of patients, and also posterior segment complications like retinal detachments or endophthalmitis, where you would need the help of a retinal surgeon. So you need to have that team. So keratoprosthesis practice can never be just a cornea practice alone. It is always in combination with a glaucoma and a retina practitioner as well. So that is something that you need to keep in mind, and that is why it is difficult. So the basic way that you differentiate whether you want to do a keratoprosthesis or an alloslet is basically based on stromal clarity. So the infrared image of an anterior segment OCT comes in really handy, which tells you whether you can visualize, like you can see in these first two images, the pupillary margin or not, or whether it is completely opaque, where you can see on the line scan also that the cornea is extremely edematous and opaque. And there you cannot do a slet, you have to do a keratoprosthesis. So ideally for slet, the underlying stromal clarity should be clear, and then you can take an allogenic graft from a donor. So here I'll just show you a short surgical video before concluding and what we typically do for allogenic slet, which is basically very similar to autologous slet. You remove the pannus, you put an amniotic membrane around with fibrin glue and glue it onto the ocular surface, and then we take a biopsy from a cadaveric limbus. Here we are taking it from a corneoscleral limb. You can also use a live biopsy, living biopsy from a donor, and this is then cut into small pieces and then pasted on the ocular surface. So you can have a patient which has severe limbal stem cell deficiency and a very aggressive looking pannus on the surface. This is a patient with bilateral LSCD due to chronic allergy, which looks like this preoperatively, and treat that patient with allogenic slet and get an outcome like this. This is the same patient post-operatively at 2 years with systemic immunosuppression with scleral lenses seeing 20/20, which is sustainable if you can give that patient that treatment. And it's not as if things can't go wrong in alloslet. You can have rejection, and therefore continuing systemic immunosuppression is important. You can also have progressive recurrence of LSCD where you might have to repeat the procedure. And there is also the risk of herpetic infections because of the systemic immunosuppression. So key messages, both these options are available for bilateral LSCD. If you have adnexal damage, dry eye, symblepharon, corneal stromal damage, disorganized anterior segment, advanced cataract glaucoma where a slet is not possible or will not help, then you do a K-Pro. Otherwise, for all other indications, an allogenic slet will be useful. Again, I'll finish by saying that if you have a patient who fits this criteria suitable for K-Pro, send that patient to a place where they have glaucoma retina support and can manage this patient. Please do not do keratoprosthesis alone in private practice unless you're Dr. Muscati. So he is the only exception. Thank you so much.
One question, would there be any point when you like to combine a K-Pro with the glaucoma drainage device too?
So typically, if the patient is a known case of glaucoma, if you have that history, or sometimes you do something called a diagnostic endoscopy to see if the nerve head is damaged, and if you have that information a priori, then typically we'll combine a shunt with a K-Pro. If you don't know whether the patient has glaucoma or not, then typically we just do the K-Pro and then evaluate, and then if required we can always go back and do a shunt later on. But it is true that a high proportion of patients will require a shunt.
Yeah, even my threshold for doing a shunt at the same time is very low. So if you do a B scan, you find cupping over there, or digital, the pressure is high in these patients, go ahead and do a shunt. It's much easier to do it at the time of the K-Pro than to wait and take serial optic nerve photographs and find it going down and then doing a shunt later on. And patients' acceptance is also high at the same time. Then you're subjecting to one more surgery, acceptance is a little low.
Is there any, how does a repeat K-Pro help at all?
Yeah, sometimes the K-Pro is extruded, sometimes there is infection, and we've all had to remove a Boston K-Pro, put a keratoplasty there, wait for the therapeutic PK to then wait for the infection to subside, and if all is well, you can go in again with a K-Pro. Prognosis not so great, but sometimes in a one eye there is no other choice.
I'll just say one thing, 10 seconds. Every keratoprosthesis will need to be replaced.
Yes.
The only question is, will you be in a situation where you can replace it in time so that the patient can sustain and retain that vision? That is where it is tricky.
Yeah.
No keratoprosthesis will stay in the eye forever.
Thank you so much, Dr. Sayan Basu. I'm sure there was a lot of pearls which the audience got to learn.